And thank you so much for joining us today. For those who are new, I am Maxine Arena. I am the program manager for the Constellation Regional Collaborative. And because we have some new faces, I just want to do a quick introduction of our team or of our team members who are here. So Kathleen, do you want to introduce yourself?
Of course, thank you. Kathleen Wellman. I am the program coordinator and ECHO lead for the Constellation Regional Collaborative. Nice to meet everybody.
All right. And Sylvia?
Good afternoon. I'm Sylvia Coleman, and I'm a strategy consultant with the team. It's good to be here this afternoon.
Thank you. All right. So our agenda for today, we'll do our introductions, and then we have an incredible presentation by Dr. Katy Wynne later today. Well, in a few moments. Then we'll go into our questions and discussion, and then Kathleen will go ahead and highlight our next session. We'll do our post-echo survey, and then we will close it out. But first, before our presentation, I just wanted to do a round of introductions for our subject matter experts. And if you are a participant, can you please share your name, your employer or organization, and your position and credentials, please, in the chat? We welcome any new of our participants. Some of our subject matter experts, they are away currently. So Honey Estrada, I believe, she has a meeting conflict. But I would like to start off with Dr. Bretler. Can you start, please? Yep.
Sure, delighted to. Hi, everyone. Jeff Bretler. I'm an internist from Los Angeles. I help co-lead the hypertension program in Kaiser System in Southern California and work as a consultant for the Pan American Health Organization for the Hearts program. And delighted to be here.
Great, thank you. And Emily.
Hi, good afternoon or good morning to those on the West Coast. My name is Emily Ridley. I'm a clinical pharmacist based out of an internal medicine residency clinic within Prisma Health in Columbia, South Carolina. I've worked in our health system and quality improvement efforts regarding hypertension control, and have also served as a consultant with PAHO with the Hearts in the Americas.
Thank you, Emily. And Dr. DePetty.
Thank you. Don DePetty. I'm an internal medicine physician, a general internist, but I did fellowship training in hypertension and vascular biology. I'm presently at the University of South Carolina and University of South Carolina School of Medicine, where I'm the Health Sciences Distinguished Professor. I've also have to confess or admit that I'm on the board of Constellation Quality Health, and I've been a senior advisor to the Pan American Health Organization and WHO as Dr. Bradley for many years regarding the heart program.
Awesome. Thank you, Dr. DePetty. Other subject matter experts, we do have Dr. Lackland, Monty Robinson, and Honey Estrada. But I would love to take this time to introduce our wonderful presenter. So Dr. Katy Wynne manages the South Carolina Tobacco Quitline and coordinates statewide tobacco cessation efforts through programs at the South Carolina Department of Public Health. With almost 40 years of experience at the state of South Carolina service behind her, she has been with the Department of Public Health, which is formerly DHIC, for close to 25 years. And she's been with the tobacco program for those years. She's also in her 8th year of graduate teaching as a part-time instructor at the University of South Carolina College of Social Work. And she has earned her doctorate in health education administration and a master's of social work degrees from the University of South Carolina, as well as a bachelor's in psychology from Columbia College. She served previously for 6 years on the board of North American Quitline Consortium and has promoted evidence-based tobacco cessation and treatment programs and services for the bulk of her public health career. So along with our many experts, you are one of them especially, and I want to welcome Dr. Katy.
Thank you, Maxine. I am very pleased to be with all of you today. I know there's some experts here. I don't know whether I'm telling you something you don't already know, because I have a feeling a lot of you already know what I'm going to present, but you may not. I may present something that's different and new. But I'm also pleased to be part of this interactive echo series. So let me get my slides pulled up and we will get started. So, ladies, if you will make sure you tell me that everyone can see my slides and can hear me. Is that good, Maxine? I see this check. Okay, good.
Yep.
All right then. Well, I struggled with how to define my entitle my presentation, but I have chosen Power to Help Your Patients Quit Tobacco. And I'm going to talk about Quitlines that provide free tobacco treatment services for cardiovascular and hypertensive patients, but of course, all patients. I have nothing to disclose related to this presentation. And of course, my thing with healthcare providers, which I'm sure those of you who are physicians and pharmacists and others here in this group, you already know this, but there's no better way to address hypertension and cardiovascular disease health outcomes while also reducing disparities in cost than to help patients who smoke or vape to quit. So we know that hands down. For our learning objectives, I'm just going to spend a little bit of time reinforcing knowledge on the primary health effects of smoking and vaping, look at the evidence-based clinical interventions for both smoking and vaping cessation treatment, learning how to access free counseling, coaching, and medication resources for patients who smoke or vape, and then recognizing special medication considerations for cardiovascular, hypertensive, and pulmonary patients. That is a lot to cover. I am going to move swiftly through these slides, but I have a lot of resources in this slide deck, which of course will be shared with all of you. You can certainly take my slides and have them and use them. Health effects. Let's talk about this. Just a little review and a refresher. There's good news and bad news, y'all. Smoking is down. We know that. Vaping is way up. So our South Carolina prevalence is right at 11.8%, which is on par with the U.S. adult smoking prevalence of 11.6%. Youth smoking in South Carolina is way down to 4%, but look at our vaping prevalence, way up to a skyrocketing 21%. The concern is that many patients continue with dual use. They might switch from cigarettes to vaping, but they're going to end up relapsing to smoking and continuing vaping. Those who suffer the most are low income, those who have poor access to health care, lower education attainment, and certain ethnic and racial disparities. Nicotine dependence is heavily linked to other addictions. And I bring the strong addictions perspective to this because vaping perpetuates addiction. And so while we've given up cigarettes, vaping is still carrying on this continued crisis that we see going on in America. Smokers have higher rates of depression and anxiety, more co-occurring behavioral health conditions. We're a drug-seeking culture, let's face it, okay? Anywhere from cigarettes all the way to prescription and over-the-counter medications and illegal substances. Y'all, we live in chronic pain. We practice poor health habits. Many Americans do. We have a mental health crisis going on, a worsening drug crisis. And there's this almost, and this is, of course, my opinion, okay? So it's just my opinion. We have this attention-seeking, almost narcissistic addiction to social media. And so folks are heavily influenced by what they see in the media. And then we have seen this since the pandemic. So many people without positive activities to fill their days, so they don't know what to do with themselves. But then there's also a lot of people that are just struggling to find their sense of purpose, doubting their self-worth, and so they're seeking to self-medicate through drugs, and whether that's cigarettes or vaping or cocaine or something else, alcohol. But 45 million U.S. adults continue to smoke, and approximately 1,200 die every day from tobacco-related diseases. So the primary health effects, this is a lot here, but we know hands down over decades of meta-analysis that smoking damages almost every organ and body system, causing 1.2 million deaths every year. It's causally linked to 8 of the 10 leading causes of death annually in the U.S., and it's linked causally as well to all diseases of the heart and lungs. So studies over decades have consistently shown that cigarette use increases the risk of cardiometabolic diseases, heart disease, heart attack, heart failure, stroke. It was a major contributor of the deaths during COVID pandemic. Again, I've already mentioned it's far more prevalent in those with co-occurring mental health conditions and substance use disorders. Damages the lungs, displaces oxygen, cellular damage, leading to heart attack, asthma attack, systemic failures. It impairs endothelial function. That's what maintains vascular health, leads to arterial stiffness, inflammation, modifies the lipid profile in your body, as well as other factors that lead up to cardiovascular events. Um, Hypertensive smokers are more likely to develop severe forms of hypertension. And then smokers overall, they tend not to adopt other healthy habits, such as making nutritious food choices, staying physically active, and getting enough sleep. When we look at vaping, there is a worldwide epidemic. I just got back from the Adriatic coast, from Venice, Croatia, down to Athens, Greece. And folks, I got to tell you, everybody vapes and everybody smokes. All these young men and women, they're all vaping and smoking. There's no obesity, but they're all smoking and vaping. And our guide in Croatia, one of the stops in Croatia, did tell us that that hypertension is a real problem in that country. Vaping aerosols contain many toxic substances. It exacerbates lung dysfunction in already sick patients, like those with pneumonia. It was a major contributor to the transplants, lung transplants in a lot of young male patients during the Valley crisis. This outbreak was in 2019. This happened in the summer of 2019 in the fall, and it was a precursor to then COVID hit, and then nobody thought about E-Valley anymore, obviously. But vaping causes which called popcorn lung, one of the many damages, but the ones that we know, we have evidence to show that scarring and narrowing of the airways in the lungs, those small airways. Um, we know that emerging data shows these aerosols show cellular lung damage and respiratory health effects. It strongly suggests links to chronic lung disease and asthma, as well as associations of dual e-cigarettes and smoking with cardiovascular disease. There's been a recent study, and I've got my references in the back of this slide deck. A recent study found that those who use e-cigarettes were twice as likely to develop COPD, and then also finding a possible association with high blood pressure risk. Um, Both smoking and vaping impede treatment and recovery. We know smoking causes cancer, but what about your oncology patients knowing that while they're going through chemotherapy and all that pain of infusions, that continued smoking could interfere with the positive effects of their treatment. And so rehab especially, we know that it interferes with surgery, but the rehab and the recovery is really important for patients to not smoke and not continue to smoke. So the bottom line is vaping may be safer than smoking all the chemicals and negative things in cigarettes, but it's not safe. It's definitely not harmless. And we are against a really strong tide of people who vape, who think it's better than smoking. We get that, okay? But if they're convincing themselves that it's harmless, that's just not true. And they're deceiving themselves as well as others. So vaping is not approved by the FDA for smoking cessation, at least not yet. But that's the way we stand. So who are the bad actors? Y'all already know this. Tar, carbon monoxide, nicotine. That tar is that sticky residue that hardens the lung tissue, causes cellular damage. That poisonous gas is the carbon monoxide that displaces the oxygen in the bloodstream. Nicotine is the psychoactive substance, very highly addictive, raises heart rate, leads to dependency. In smokeless products, it's the tar and the nicotine. And yes, nicotine occurs naturally in leaf tobacco, but y'all, the industry knows how to manipulate even growing leaf tobacco, as well as synthetic nicotine that's developed in the labs. In electronic devices, there are 5 times more nicotine. There is 5 times more nicotine in electronic devices than in cigarettes, at least 3 to 5 times more. A lot of patients don't know that. And what's interesting is they're designed to look like, something else, like USB drives. Now, y'all, can you believe this? They've got electronic e-cigarettes that are in your smartwatch. And so I'm thinking, They never give up. The industry never gives up in creating some new thing. Zen is the latest thing, nicotine pouches. Those are nicotine salts that have fillers and stabilizers and sweeteners and God knows everything else in it. So why Zen? The reason I'm bringing this up is that this is the latest craze, y'all. It's not the most used product, but it is the most heavily growing product. It's disguised for cessation, but don't be deceived. It is not a cessation product. It's the biggest new money maker for Philip Morris. It's the fastest growing product in the market, especially among young adults. If you followed the news, you've seen that British female golfer, the 28-year-old Charlie Hull, who she went viral last year for smoking on the golf course during the US Open. So she decided she would quit. Well, she quit cigarettes, but she didn't quit nicotine. So she has now in 2025 traded smoking for the nicotine pouch, a UK brand. So you'll see that in her while she's out on the golf course. She's 28 years old, y'all. She's a world-class golfer. She's an influencer. She's influencing young people by using the nicotine pouch. So this is a long list of ingredients. I'm not going to go through all of them, but do we really want that in our bodies where the mucosal, you know, lining of your mouth is getting that right straight into your bloodstream? No, we don't. So the health effects, I've got to keep moving here, but the health effects come with a high cost, y'all. So it's clear that smoking is a major contributor to our skyrocketing medical cost. $96 billion from smoking cost in the United States, over $2 billion just in South Carolina alone. The financial burden, when someone in South Carolina says, I cannot afford to retire, but they smoke, share this data with them, share this figure with them. 2.3 million is what's projected a South Carolina smoker could spend over their lifetime on smoking. With vaping, in 5 years, they could spend over $25,000. Y'all, that's a lot of money for people to spend. So if they say they can't afford to quit, how can they afford to continue using? In terms of years of potential life lost, we're looking at 10 to 25 years lost for a typical pack-a-day smoker. And just a few statistics that alarm me is that there's over 32% of cancer deaths in South Carolina are attributable to smoking, 36% of cardiovascular disease across the nation, and 12.4% of stroke risk worldwide. So the last of these slides is tobacco's deception is that tobacco is still grown as a major crop in South Carolina and our other sister states like North Carolina, Florida, Tennessee, Kentucky. Hundreds, if not thousands of products are still in the pipeline. And despite the tobacco settlement of the 1990s, big tobacco has not gone away. They just keep reinventing themselves, y'all. They own the vaping industry. And let's not be deceived, they have deep bipartisan pockets. Both the tobacco and vaping industries are major contributors to both the Republican and Democrat parties, and they contribute heavily and lobby heavily in Congress and locally in our states, in our state legislatures. So I call them the tobacco cartel. Maybe that's too rough, but no, it's not. They still have multiple billions of dollars laying around to play with. The vaping industry is worth $22 billion worldwide. And get this, y'all, global tobacco industry is valued to reach over $1 trillion by 2030. So what is it that we do not know? Because I have to be fair here, okay? We really don't know yet the full scope of the health effects of vaping. This is an evolving area of research and study. We really don't know if vaping helps with quitting because there's a good number of clinical trials. Some of you may be involved with some of these clinical trials, looking at vaping and does it really help people quit? And so the jury's still out on that, okay? We don't know how marijuana smoking and vaping will intersect, but I promise you they will. And as more states continue to legalize marijuana, not just for medicinal use, but recreational use, we're going to see issues come down the pipe. That's my personal, but also professional opinion. We don't know the ongoing influence of social media in the markets, but we know it's strong now. Why would it lessen up anymore going forward? And we don't know what big tobacco is going to create next. So y'all, for these health effects that I sailed through, go to Appendix 1A and Appendix 1B, and that's got more data and more links for you there. So, clinical interventions for smoking and vaping treatment. Some of you know this well, but the benefits of quitting are huge. Overall improved health status, enhanced quality of life, reducing premature death. It can add as much as 10 years to life expectancy, and it can reduce many adverse health effects, including poor reproductive outcomes, cardiovascular diseases, COPD, and cancer. There's faster wound healing following surgery and rehab, healthier babies, fewer asthmatic episodes, better response, as I've mentioned, to chemotherapy and other treatments, less recurrence of illness and relapse from remission. And of course, quitting reduces the financial burden that smoking places on people who smoke, on healthcare systems, and on society as a whole. Now, the immediate effects of quitting, once you put out a cigarette, it immediately lowers the heart rate and the blood pressure. Things like hand tremors, stop, less CO flowing through the blood, better circulation, less coughing and wheezing. Now, I will admit, obviously, when someone puts a cigarette down and quits, their lungs automatically starts to clear, and there'll be more coughing and getting all that gunk up out of their lungs. Did you like my professional term, gunk? But it is gunk. But eventually, the coughing and wheezing will subside considerably. Of course, there's instant cost savings, but this is important that I really want to drive into healthcare providers' minds is that it's never too late to quit. Even smokers over age 65, 70, and 80 can benefit greatly from abstinence. The oldest person who quit with South Carolina's tobacco Quitline was 100 years old. Isn't that something? And I like to share that fact. Older smokers who quit can reduce their risk of coronary heart disease, COPD, lung cancer, as well as decreasing their risk of osteoporosis. And I believe that smoking also has a link with dementia. And there's just not enough time to go into all the connections. But I do want to say I want to include this slide with all my love and support. There is a hesitancy for a lot of providers to intervene. Obviously there's time constraints because busy providers who dealing with patients or in a hospital setting, they think patients don't want to quit. They're unsure maybe of how to help. Maybe the patient is too sick or old, their definition. Maybe it costs too much to quit. They don't know of qualified treatment resources. And maybe their patients might get upset if they bring up the subject. We know that none of these really hold true, that we know that there's time constraints, but there's a way to do brief interventions that work. Patients really do want to quit. So when you get started, these are powerful words. I can help you quit. And just saying that to a patient, to a smoker, to a user, can help them build that efficacy, knowing that they've got someone on their side. The medical influence on patients is huge. Quitting smoking is one of the most important actions they can take to improve their health, regardless of their age or how long they've been smoking or vaping. There are numerous reasons to treat patients who smoke or vape, and most adult smokers, up to 70% or more, really want to quit, even those with a diagnosed mental health condition. They know they need to quit. They know they want to quit, and they just don't know how. So the evidence-based interventions are very simple. They have not changed. The gold standard of tobacco cessation and nicotine treatment is counseling plus medication. And so the counseling would be using all those behavioral coaching support techniques, such as motivational interviewing, cognitive behavioral therapy. It is best delivered by trained tobacco treatment specialists, and all of our most Quitlines have TTS trained coaches. But that doesn't mean that anyone can't be trained. Even an office manager or a medical technician in a practice can be trained to do brief tobacco intervention. And then along with the medication that are FDA approved products, vapes again are not approved by the FDA for smoking cessation. And these are your nicotine and non-nicotine products available over the counter and through prescription. So when you take evidence that I just showed you to practice, it's important first to realize that tobacco use is a chronic relapsing condition. So that means it needs consistent and continued intervention. As they say, ask every patient at every visit about their use. There's decades of science and proven research have established these interventions that have listed, like brief tobacco intervention, personal coaching support, active listening, motivational interviewing, relapse prevention strategies. That's just a small list of the types of behavioral counseling techniques that can be used to really support somebody and build their efficacy and success on quitting. And then combining that with prescribing either nicotine replacement therapy products or non-nicotine prescription meds, but also considering combination therapy, prescribing combo of these meds that we're going to look at in just a minute. So here's some intervention options. I put this table up that if there's a provider to patient, this on-site intervention, the counseling involves ask, advising, and referring. Coaching is like in-office encounter, advising to quit, one-on-one support, connecting with health concerns, and then prescribing the appropriate products for that patient. If it's the quit line to the patient, it can be either a phone or virtual intervention. So we enroll them and engage them. The provider makes a referral, hopefully, and it's coached to participant using these behavioral techniques, ongoing support, and resources. And then dosing and dispensing, as our Quitline does, NRT over-the-counter products, patch gum and lozenge. And then there are local programs. A lot of hospitals have very, very good local programs. Here in Columbia, I know Emily, you're the one with Prisma Health, but I use Lexington Medical because I'm on that side of the river. Lexington Medical has an ongoing smoking cessation program, and I think Prisma Health does too. So enrolling them in local programs, these are on-site classes, facilitated sessions that provide group support and educational resources. I will say, though, the medication availability will vary per program. So the brief tobacco intervention is just 3 simple steps. Ask about smoking in a personalized, engaged manner, advise to quit, refer to a treatment resource, or intervene right now. And these prompts here, do you mind if I start talking about smoking? Or saying, you know, the best thing for that nagging cough is to quit. And as your doctor, I'm really advising this for you. But the power comes in saying, I can help you quit by prescribing medication or making a referral to free services or both. Let's talk about it. So BTI, or brief tobacco intervention, works at bedside, intake, discharge, exam room, rehab setting, even in the waiting room. It's just a matter of just deciding that this is how we're going to insteep this in our practice and make it standard practice behavior. It works while patients are receiving extended treatments like chairside during chemotherapy. So if y'all will see Appendix 2A, 2B, and 2C, there's more information on benefits of quitting, evidence-based interventions, and provider prompts to get the conversation started. Okay? So let me talk about access points. Many, most all doctors know how to ask their patients about quitting, and many, many do. That's been established through numerous surveys and tracking data. But and they'll advise them to quit. And they'll do some type of intervention with the patient while they have them in front of them during a patient encounter. What a lot of providers I find don't know where to go next. And even after we've had our next year will be our 20th year for the Quitline in South Carolina. And y'all, we're the youngest Quitline of all across the nation. South Carolina, well, I think a few came after us, but we were one of the last states to get a Quitline, and that was back in 2006. So, I mean, California's had their Quitline for decades, but a lot of providers still have never heard of the Quitline. So our work is not done, y'all, as long as there's one doctor or one nurse practitioner or one nurse that has never heard of the Quitline and these free services, then we've still got work to do. So our Quitline works, y'all. In South Carolina, we provide 100% coaching and medication support. It's all free for patients and easy for providers. Our Quitline is open 24/7, except on just a few major holidays. We're even open on New Year's Day. South Carolina has one of the highest quit rates in the nation because we've invested cigarette tax dollars into providing the most comprehensive services that we can. Now, y'all, I'm a native South Carolinian. We're behind on a lot of things. We come up the laggards on the health belief model. And I say that with all the love of my state. But I can tell you right now, our Quitline is one of the best in the nation. And I'm not just tooting my horn, I'm tooting the horn of all of the collaborative team that we have, and all of the partners that we've worked with over these couple of decades. Our quit rate is 41%, and that exceeds the 30% quit rate of most other states across the nation. We've served over 250,000 residents since we started. We do provide free training and technical assistance with even lunch provided to supplemental providers. So there's links on how you can access our health systems optimization team to work with any of your provider settings. We provide free technical assistance and training for converting from fax to electronic referrals. And there's your inquiry. Just go to SC Referral Hub at tellas.com and you can put in an inquiry and get a free consult. And then the referral methods, there's more about those at this link on our Quitline website at quitnowsc.org/healthcare-providers. So enrollment. Anyone can enroll in the Quitline. There's 2 phone lines. Actually, there's several phone lines, but the Quit Now is the English and the Delejo Ya is our Spanish line. They're toll-free, free call. Online, they can go to this link at quitnow.net/South Carolina and get started online, or they can text READY on their phone, on their mobile phone, to 34191 and then follow the prompts and use this to get enrolled. But what we love is to encourage providers to refer to the Quitline using the fax referral form that we have a brand new form that we're rolling out right now that makes it easier to use. It's a fillable PDF, and just fax it to the Quitline, or go online to the Rally Coaching site. There's the link, and it'll be in these slides that you'll have access to, and complete the online form and submit it. Or do it from your EHR, from your system's EHR. And again, contact SC Referral Hub at tellas.com and they'll work with you on a free consultation. We work with health systems and practices to implement electronic referrals, and we are underwriting those costs for practices for implementation. It saves provider sites up to $10,000 per implementation, and that's replacing the fax form for referrals. So there's no excuses. I've been doing this a long time, y'all, even before we had a Quitline. There's no excuse. Tobacco cessation support is free for most patients, if not all. There's multiple billing and coding mechanisms in place to reimburse. The Quitline is free. There's Medicaid reimbursement, Medicare reimbursement, private health plans reimburse. So what I've done is I'm calling your attention to the Million Hearts protocols that have have a tobacco cessation change package. Here is the link at Million Hearts at .hhs.gov for the change package on tobacco. But what they also have on that page that may be of interest to y'all is they have evidence-based protocols also for cardiac rehab, cholesterol management, and hypertension control that some of you might be interested in. If you'll go to this link at quitnow.sc on our website and scroll down to coding and billing, you can pull a comprehensive coding and billing guide for all the codes and billing guidance for nicotine dependence. So again, for this section, if you will see Appendix 3A for more information about the Quitline and reimbursement resources, then that'll fill out that section. So let's wrap up with pharmacotherapy. I'm a little nervous. There's a PharmD here. So Emily, watch out. So this is what I pulled together. You'll correct me if I'm wrong. Oh no, it's general information. So y'all, these are the pharmacotherapy options. Again, you're not going to see vaping on here, okay? There are 7 FDA-approved medications for smoking cessation. They're available over the counter. They're available through prescription. And the transdermal patch, nicotine gum, and nicotine lozenge are readily available over the counter in all of those different strengths. There's the nicotine-based nasal spray. Yes, it was off the market for a little, or was it the oral inhaler? I can't remember which of those was pulled off, but that was strictly a demand. They couldn't find the mouthpiece was out of stock and couldn't, but I think it's back on the market now. Nasal spray and oral inhaler are both nicotine-based products and are prescription-based. And then your non-nicotine prescriptions are your bupropion and varenicline. And of course, bupropion is the generic for Wellbutrin. Varenicline is the generic for Chantix. Sometimes you'll still see Zyban. I thought Zyban had been discontinued by the FDA, but you'll still see the word Zyban used for bupropion. But combo, I want to really drive home the importance of considering combo prescribing with a long-acting NRT plus a short-acting one, like the long-acting patch plus the short-acting gum, which gives that continuous nicotine to help with those cravings. But when a craving does happen, the gum or the lozenge can help with that burst of nicotine to help them through that moment. Or the bupropion or varenicline plus a short-acting NRT. Now, I will say this jury is still out and the evidence is still building on the efficacy and effectiveness of using varenicline plus a short-acting NRT. But bupropion plus the short-acting NRT, like patch gum or lozenge, works very well. So pharmacotherapy considerations for certain patients. For what we do with the Quitline is we have medical oversight. We'll get a medical waiver from the physician if any of these present with our participants. For cardiovascular and hypertensive patients, if they've had a recent heart attack or stroke, or a recent heart surgery or excessively high blood pressure, we get a waiver. For pulmonary patients, recent surgery, if they're recovering from pneumonia or have other severe comorbidities, we will get a physician's waiver. And then patients with co-occurring behavioral health conditions, if they present or admit that they have suicidal ideology or there's threats or attempts or a severe psychiatric diagnosis, we will want to get some additional clearance. So recent heart attack, recent heart surgery, uncontrolled blood pressure. For these heart and hypertension patients, do not prescribe nicotine-based products within 2 to 3 weeks of heart surgery or heart attack or a stroke, and consult, obviously, their pulmonologist or cardiologist first. You may need to start with lower doses of nicotine-based products and monitor blood pressure and heart rate. And the nasal spray does interact with some blood pressure medicines, so those contraindications are there. And things to consider. With pulmonary patients, the medical considerations I've already mentioned about the lung transplant or other respiratory related surgery, recovering from pneumonia or severe comorbidities. With the oral inhaler, it should be prescribed with caution if patients meet the above criteria. And of course, the medication use requires being able to use an inhaler properly for correct dosing. With the nasal spray, it can interact with certain medications for lung or respiratory illnesses, such as asthma and COPD, so it may not be advised for patients who already use inhalers or sprays for lung conditions. With behavioral health patients, hands down, y'all, varenicline has been established as the most effective smoking cessation medication that's approved by the FDA. It is even more effective than nicotine patches and bupropion, with similar or fewer adverse events, even with comorbid psychiatric and substance abuse conditions. So patients with behavioral health conditions, they're highly susceptible to relapse. So combo therapies are really supported in clinical trials and may work best in this situation. So a suggestion would be the nicotine patch plus gum lozenge or even nasal spray as needed for situational cravings, or sustained release bupropion plus, say, the patch. So bupropion and NRT products are good choices for patients with diagnosed mental health conditions unless contraindicated. The patch should be removed at night if the patient presents with nightmares or sleep disturbances. And then varenicline, even though the FDA did remove the black box warning, it can still be prescribed for patients with co-occurring behavioral health conditions with close monitoring. Again, caution should be taken if there's been a recent psychiatric event or patients with severe mental illness, and avoid prescribing for patients who have suicidal ideology, threats, or attempts. General precautions. Just realize that nicotine is still toxic and addictive. Keep it out of the reach of children and pets. Poisoning, suspected nicotine poisoning should be considered a medical emergency and call poison control and treat it immediately. Pregnant smokers should be encouraged to attempt cessation using educational and behavioral interventions before using any pharmacological approaches. But we always defer our pregnant and postpartum participants back to their provider, because some providers do prescribe. Because disclaimer is for any smoker with or without concomitant disease or pregnancy, the risk of nicotine replacement should be weighed against the hazard of continued smoking. And y'all, the hazard of continued smoking is always going to be the worst. But obviously there's situations where you shouldn't use any products and you should be cautious with pregnant smokers. Here's some prescribing guidelines. The first one is the one I suggest that you go for. It comes from RX for Change, and it is the newest. It was updated in January of this year. And so this is a product guide that is the one that pharmacists and physicians use. And then you also have a link at the Academy of Family Physicians, and the NIH has prescribing guidelines, more information as well. All right, these are the appendices that I have in the slide deck, and then the references that I have included, and then how to reach me. So what I'm going to do is I'm going to stop sharing, and this is the fun part, y'all. Hang on, I've got to get going to get to my other slides. Don't y'all love this? I teach grad school virtually at USC, University of South Carolina. And I do this every week. Of course, the semester's over now. All right, y'all. Now's where y'all can shine, because I know you're as smart as I am, or smarter. Some of you are a lot smarter. All right, I picked some case studies, okay? Tobacco intervention case studies. Y'all hang in there with me. I know it's 12:44. We're going to be fine. We're going to do this with Q&A. No disclosures. I want to make it very clear these case studies are for practice purposes only, based on fictional characters. Any resemblance to actual patients is unintentional and strictly a coincidence. I also want to say, because there's some real MDs on here, I'm an academic doctor and not a medical doctor. Therefore, these fictional scenarios are intended for educational purposes only, as case examples in tobacco treatment. That said, while the information presented is grounded in science and applies evidence-based principles, always consult with a qualified medical and healthcare professional when making any diagnosis or treatment decisions. All right, let's jump into this. So I chose Linda as our first case study. All right, y'all hang in there with me. Linda is a 42-year-old white female. She has a BMI of 36, which is class 2 obesity. She has gastric reflux. She takes omeprazole one time a day. She has elevated blood pressure, 150/80. She's a pack-a-day smoker, but she doesn't smoke menthol cigarettes. She is seeing her family physician today for shortness of breath while walking upstairs and during physical exertion. She was recently treated for acute bronchitis from a upper respiratory infection, and still has a lingering cough at night. So, first question is, what are some things that should stand out first to her doctor? I'm going to go back to this slide. So if you will, just feel free to unmute yourself and just speak up. What are the first things that should stand out to her doctor when she's seeing her doctor today? Or either type in the chat and Kathleen can share it with you.
Elevated blood pressure.
Absolutely. Elevated blood pressure.
Shortness of breath.
Shortness of breath, exactly.
Or BMI.
Okay. Yes. Very good.
GERD.
GERD, exactly. Okay, so assuming her doctor has not screened for smoking or any tobacco use, what's the first step for her doctor to take during Linda's examination?
Ask about her daily activities or things that she do.
Okay, good.
And, you know, the questions that we ask here is, we ask our patients, are you a smoker? Do you exercise? And all that good stuff.
Sure, exactly. You know, and listen, all your patients have to fill out a health history anyway, and it should already be in the EHR. It should be documented. So that as a provider, you can easily say, I see in your chart here that you said you're a smoker. Tell me more about that. You know, that could be a conversation starter, couldn't it? I think I just answered the third question. After screening, what could the doctor say to Linda that would be a motivational response?
A lot of other people in her position, and they've successfully quit smoking, and the doctor could help.
That's a great answer. Very good. That's a great answer. See, this isn't that hard. It's not rocket science. All right, let's move on. So in the discussion review, What stood out to me is as y'all said, Linda has a lingering cough even after treatment for bronchitis. She presents today with slight hypertension. That may be high hypertension for some of you, but I think it's slight. She is overweight and struggles to breathe when active. And the doctor can likely smell, she's a pack-a-day smoker, y'all. The doctor can likely smell smoke residue in Linda's clothing and skin, but that doesn't mean the doctor has to say, I smell smoke on you. But what you said is that, a lot of people struggle with quitting, let's talk about it. And that the second question is simply asking about any tobacco use and exposure and documenting in the chart. This is the first step to the 2As plus R ask. And then that last question, the doctor could say, as you indicated, some of you indicated, many people still smoke, and I admit it's a very hard habit to break because y'all, it is a very hard habit to break. It is actually a dependence on nicotine, but to quit would go a long way to help you heal your lingering cough and to help lower your blood pressure. I can help you quit. Do you want to give it a try? Okay. Let's look at Michael. Michael is our second case study. He's a 65-year-old Black male, has type 2 diabetes. He has taken metformin for years, but his doctor wants to try him on one of the new GKP-1 agonist drugs that everybody's taking. He had a mild heart attack 2 months ago, but he's made a full recovery. He's a half a pack a day menthol smoker. He did quit smoking just after the heart attack, but started back a month ago. He's having a follow-up appointment day with his cardiologist. And he tells his doctor that he experiences some days in a depressive mood and is concerned about resuming his active lifestyle because of his heart attack, which is normal. So Michael's cardiologist has screened him before for smoking. What could the doctor's follow-up response be at this visit? Remember, he took back up smoking.
Well, he could ask what triggers caused him to revert back to smoking.
Mm-hmm.
Is that what you're?
Yeah, exactly. Just start that conversation. I see you started back smoking. Tell me what triggered that. What's going on. Just tell me more about that. And do that active listening and let Michael talk about it.
Yeah.
Exactly. So having had a recent heart attack within the past 2 months, what cautions should his cardiologist take with prescribing quit medications? I know our internists know the answer to this.
And I don't want to be the only one answering the questions either. I don't want to. I know I'm the star student, but
You're fine. You are the star student. You get
I want to
an A. You get an A.
I want to let somebody else shine.
No, go ahead and share what you want to say. I want to hear it.
God, no, go ahead, Chris. Go ahead.
I was going to say his blood pressure may be a challenge in this.
Yep. That is true. And I've not given what his blood pressure is, but absolutely you want to be tracking that. And he's a menthol smoker, and so there's more going on there with the menthol. So how could a combo prescription benefit Michael? Remember what he said?
Probably help with his depressive symptoms.
Okay. What I put on here is that, yes, his doctor should ask about tobacco use at every visit. This would reveal that Michael recently started back smoking his menthols, and that way the cardiologist can gently probe some more and learn more about, like you said, that Michael has been dealing with depression from the heart attack and is self-medicating his stress with tobacco. So nicotine is a stimulant, and like you said, monitoring his blood pressure, it can raise blood pressure in higher amounts. So the cardiologist would take that into consideration when dosing nicotine medications or prescribing it. So the combo piece is, barring any contraindications, a combo of prescription of bupropion for depression and the nicotine gum lounger patch could better curb cravings and amp up quit success. Even varenicline might be a good choice for him. And then specifically telling him to go get the cinnamon flavored gum that could offset the menthol cravings. Because menthol, African American smokers smoke menthol cigarettes. The tobacco industry clearly markets directly to African Americans for menthol cigarettes, and it's become an epidemic. There was a ban. The FDA proposed a ban on menthol cigarettes. The Biden administration put it on hold, and then the Trump administration just canceled it. So there's no ban on menthol. There you go. Thank Washington. So our last case study, because I'm looking at the time, y'all. I'm realize, Kathleen, I'm gonna wrap it up right now. Case study 3 is Daniela. She's a 24-year-old Hispanic female, BMI of 28, which is just on the upper end of overweight. She has a history of childhood asthma. Both parents have hypertension and are overweight. Her father had a stroke a year prior. She smoked in high school, but now she vapes 3 pods a day. She's seeing her family physician today for a refill on her asthma inhaler and a general checkup. So let's go through this kind of quickly. Daniela's doctor knows of her struggle with weight and asthma that is largely controlled. Her doctor also knows she smoked in high school and suspects that she now vapes. What could the doctor's approach be today?
I think her family history would point her towards, also having high blood pressure and perhaps a stroke.
Absolutely. Absolutely. That's a red flag, especially with the amount of nicotine she gets in those 3 pods. Exactly. What FDA-approved medication or medications might be a smart choice for Daniela to overcome vaping? I'm going to move on then. It's okay if y'all don't have an answer because this is my last slide or two. Okay. So this is the hard one, y'all. This was kind of a tricks case study for y'all, I admit. Daniela is young and smart. She already knows that vaping might not be great, but she thinks it's better than smoking. What she does not know is that 3 vape pods is equal to the amount of nicotine in 5 packs of cigarettes, y'all. And that's a fact that her doctor can tell her will absolutely be bad for her lungs and will exacerbate the onset of asthma attacks. Nicotine is a poison, and too much of it in the body can be dangerous. So the FDA-approved medications, this is not an easy answer because getting young people to quit vaping is a huge challenge given the social media pressures today. But a smart choice could be starting her on a high-dose, long-acting nicotine patch that she wears all day for sustained nicotine release, and then having her also use the nicotine gum when she has an immediate urge to vape. That quick burst of nicotine can help her through that moment, and this combo, although higher than normal, would still be lower than the amount of nicotine she is consuming currently, and then monitor and taper her down in product dosing. Now, I don't claim to have the perfect answer for these 3 cases, but I wanted to show you how thinking through a patient's vitals and history and use pattern, but just getting the conversation started is what the most important step is. And so I'm going to open up for Q&A. Again, thank you. Y'all did quite well. This is my contact information and how to reach me. Y'all can have both of these slide decks and they'll be available for you as well. And I'm happy for questions. And I realize that I've not left any time for sweet Kathleen, my counterpart.
No, you
Kathleens
are
here.
fine.
Doctor, the real doctor.
Kathleen, I'm sure Dr. Bretler and I we're just too shy. But I've never been accused of that. But nevertheless, you did mention it in passing, Kathleen. How does cannabinoids, whether you're smoking cannabis or now the Delta 8s and all these other, my goodness gracious, I can't keep track of that. They're right side by side with the vaping shots. So
I know.
how does that complicate our care issues, synergistically bad, additive bad, or not bad at all?
Well, Dr. DePet, is it DePet?
DePetty.
DePetty. I'm sorry, Dr. DePetty. I should
That's
know
okay.
your
I've been
name.
called worse things.
Dr. DePetty, you know what? Let me tell you something. They're psychoactive substances, just like nicotine, and they're going to have if you're smoking, you're still getting that smoke and those vapors and aerosols, whatever the cannabinoid vapors are, you're getting them into the lungs. So obviously there's going to be negative effects. But I've got to say, I am starting to do more and more research just to see where we're headed. But hands down, our Quitlines are going to start embracing treating marijuana users, pot smokers, I still call them. Y'all, I'm a child of the 60s. Smoking pot's nothing new, okay? I mean, it was big then, Woodstock, remember? I wasn't there. But anyway, I think more and more doctors are going to be grappling with how to treat all of this. And the Valley cases back in 2019 were from vaping devices that had been used up with the nicotine, and then they were stuffing the THC, they were stuffing the cannabis into the vaping pods. And that's what caused the lung damage, lung collapse, and the need for lung transplants. So what's happening is they're taking vaping devices and stuffing them with cannabis. And so that's going to cause even more damage. And so we're waiting to see more evidence on the damage there, but there's obvious damage to the lungs. And then, of course, I don't know about cannabis raising blood pressure. Some of you may know that better than I do, but it cannot be good for the heart. It's not good for the lungs, but it cannot be good for the heart.
But the other problem we're seeing, Kathleen, is maybe not even the smoking component, but all these other products, these gummy, Delta 8 gummies and cookies and God knows what.
Well, we already know with vaping pods, there are other states that, like a decade ago, were starting to have, at least 5 to 10 years ago, starting to have calls into the poison control with children, ingesting 2-year-olds dying from ingesting those pods. Same thing with the cannabis, pods, all that, everything is a real concern.
Wow. Thank you, Kathleen.
It is a moving target that is coming so rapidly at us. We're not quite ready for it yet, I think.
Thank you.
Thank you, Dr. DePetty. Kathleen, I'm going to defer back to you.
Okay. Well, Dr. Wynne, thank you so much for the presentation. It was just amazing, and we really appreciate you taking all that time to let us know all about this. It's just amazing. We will have all of your slides ready in iEcho. So that way everybody can take a look at those. They'll be able to see the resources. So they'll be able to reference back to those.
Thank you.
Of course, thank you. Our next Echo session is Thursday, June 26th. It's going to be from Food Share South Carolina, and it's going to be on Food is Medicine and the Veggie RX programs. Dwayne, who is the Director of Culinary Medicine, will be presenting the didactic and the case review. And from our team, we would like to just tell you thank you so much for participating, and we love seeing you guys. The after Echo survey will be popping up in just a few seconds, and I would truly appreciate the feedback on that. That way we can go ahead and just keep making this Echo more and more to your liking and satisfaction. I hope you guys have a great long weekend coming up, and we truly appreciate you guys joining us. Have a great
Thank
month.
you all so much. Thank you, Kathleen. Thank you.
Dr. Wynne, you're my new favorite person.
Nikita, you're precious, and you get an A for today. Dr. DePetty gets an A too. Thank y'all. Y'all take
A+.
Y'all take care. Yeah.
Thank you.